On behalf of the Center for Family Research at the University of Georgia and our co-sponsor, the College of Public Health, it is my pleasure to welcome you to the Gene Brody Symposium. I'm Steve Kogan, a professor in the Department of Human Development and Family Science. For the past 20 years, it has been my privilege to work as part of a dynamic team at our center, founded by Dr. Gene Brody, Regents Professor Emeritus. We are currently led by Regents Professor Dr. Steve Beach. The Center for Family Research conducts pioneering studies on the ways in which stress affects family relationships, youth development, and adult health, with an emphasis on Black Americans in the Southern United States. Central to this research is investigating how structural racism and discrimination affects the development and well-being of Black Americans. Building on this work, we partner with community stakeholders to develop preventive interventions that promote youth and family health. In this annual symposium, we host an intimate conversation with an outstanding senior scientist who is driving the field forward by initiating dialogue among researchers, policymakers, and practitioners with the goal of fostering a more just and equitable society. Leading today's conversation and introducing our featured speaker is Dr. April Few-Demo. Dr. Few-Demo is the University of Georgia Foundation Professor in Family and Consumer Sciences and Department Head in Human Development and Family Science. Her scholarship embodies a long-time commitment to examining how marginalized individuals and families experience social disparities and how they engage in decision-making processes that promote personal agency, resistance, and resilience. Welcome, Dr. Few-Demo.
Great. Thank you, Steve. We are excited to have with us today someone whose work in public health has had an enormous impact on understanding health disparities and policy-level interventions for health equity. Dr. Deborah Furr-Holden moved from Michigan State University to become Dean of New York University's School of Global Public Health about a year and a half ago. As an epidemiologist and public health professional, her work has examined a range of health-related topics, including drug and alcohol dependence, violence, and prevention science. I'd like to add that Dean Furr-Holden is the recipient of numerous awards and honors, including the White House Presidential Early Career Award for Scientists and Engineers. She was elected as a member of the National Academy of Medicine because her research has driven multiple policy initiatives to improve behavioral health and eliminate racial, economic, and geographic disparities in intentional and unintentional injury, including opioid-involved overdose death, gun violence, and community violence. I want to end her introduction by stating that the election to the National Academy of Medicine is considered one of the highest honors in the fields of health and medicine. So this is a particularly special privilege. And joining me now from New York is Dr. Dean Furr-Holden.
Hi, April.
Hi. I'm not done. We are so honored to have you with us, Dean Furr-Holden. Our frame for this conversation begins with a thank you. Thank you for taking time to have a conversation with us about your personal journey of becoming, and that's a quick reference to First Lady Michelle Obama.
I got it.
But also a signal that your work is not done yet. Your story of becoming a scholar and activist whose work has given us community-engaged, evidence-based, health equity-driven solutions for addressing and ending historical racial, economic, and social disparities that impact health and behavioral outcomes. And I'm hoping that you'll also share with us your stories behind the development of NIFTY, the Neighborhood Inventory for Environmental Typology, your groundbreaking and heartbreaking, I have to say, discovery that specifically Black, and also brown communities were outpacing whites in opioid involved overdose deaths between 1999 and 2018, which is just prior to the pandemic. So I'm curious about your thoughts about where we are now with this. And finally, your insights into developing sustainable community engaged research that is participatory, inclusive, and non-exploitive. So we're not actually asking a lot from you today. We want to get it all in.
Yeah.
And for our audience, please see the relevant papers in the chat, or maybe they'll pop up. So let's begin with you. Would you share impactful experiences in your personal or professional biography that has led you to public health, but also to pursue social justice imbued projects the way that you have? So, what's your story, Deborah? What's your home place, as Bell Hooks would say?
Well, I can tell you, my family, I'm known as Little Debbie. And I'm Little Debbie from Seat Pleasant. I grew up in Seat Pleasant, Maryland, mostly, which is a very small area right outside of what we call the DMV, the DC, Maryland, Virginia corridor. My mom was a teenage mom. I'm the youngest of three. She had her kids at 15, 17, and 19. And I share that to say it is possible for people to raise amazing scholars, doctors, lawyers, train conductors. People can thrive, but we need conditions that are conducive for that, right?
That's
So
right. That's right.
a lot of these, I hate the idea that we give people life sentences or we make judgments and assessments about people. I always tell people I was not the first in my family to go to college, but I was the first one to graduate. So I know that brilliance is spread evenly, but opportunity is not. And given the opportunity, no matter where you come from, everything is possible.
That's
So,
right.
yeah. So my work is because, I went to college and I was surprised at how many colleagues and classmates had not only living parents and grandparents, but great grandparents. My original roommate, my freshman year in college, she kept saying her gam gam. Her gam gam was sick and her gam gam died. I thought it was her grandmother. When she got back, I found out it was her great grandmother. I didn't know anybody until I went to college. I went to college with one living grandparent and one living parent. And most of my peers had living great grandparents. And I realized the lived experience that I had of people living sick and dying young was not the common experience. And I saw there was a big difference based on two factors: race and income. People who were wealthier, independent of race, seemed to have more living parents and grandparents and great grandparents. People who were white had disproportionately more living parents and grandparents and great grandparents. So it was like eye-opening for me, and I thought, this isn't right. So I actually went to college pre-med and I sort of stumbled into public health. And what I realized is this isn't fair. It's not fair that people live sick and die young. So what can I do about that? And so here we are. I pivoted. I'm in public health and I have devoted my entire life to people experiencing health and everything that one would need to live healthy and live long and have that be a birthright and not a privilege.
I hear that. I hear that. So many things that you've just mentioned here echoes in my own biography. So, yeah, so thank you for that. Thank you for sharing that. Let's talk about one of your most highly visible contributions to the field, the NIFTY. And the beauty of this method is that it lays bare measurable social determinants of health and mental health, which are derived from the intersection of structural racism, systemic biases, and disparities. So would you explain to us why this method is necessary bread or really foundational for implementation and prevention science?
So one of the ways that we have in the past thought about and tried to describe how where people live impacts how they live
Right.
is we use census data. But here's the problem with census data. Census data was designed, and the system that we use for the census was designed around the postal system, right? These census tracts and zip codes.
That's right.
It was all about getting mail to people, right?
That's right. That's
It
right.
has nothing to do with community. So there are census tracts that in no way, shape, or form map on to people's actual sense of community. If I were to ask you, April, what census tract do you live in? You don't know.
No.
But if I said, what neighborhood do you live in? You that's right there for you. So
Right.
I wanted us to be able to say, we now know this. This, when I started the work of the Nifty, people weren't talking this way. That place matters, that where you live, your zip code is a stronger predictor of your life expectancy, even than your genetic code, right?
That's right. That's right.
I thought, let's get a better, more resolute system for being able to not just characterize neighborhoods, but understand what are the features of neighborhoods that might either promote or prevent good health. And if we can identify those features, if they're malleable, then now we have a potential target for intervention. So it's not just about describing the problem, but having a tool that also points us to how to solve the problem. And that's why you'll hear me talk more about solutions. As an epidemiologist, we're very good at counting and describing,
That's right.
right? But what we actually need, and I think this is sort of the revolution afoot in public health, is we need to then use what we've learned. How does that data then inform what type of interventions need to be done? And I personally have worked mostly at a systematic, structural, and a policy level, because that's where I think we're going to get the biggest bang for our buck.
So when you describe that, is that upstream or downstream that we should
Yeah.
focus?
Yeah. So there's an expression, right? Like the stuff rolls downhill.
That's right.
We do a lot of work downstream. And I always tell people, for all of my program people, programs are amazing. I'm a program kid. I was in a busing program. I didn't go to school in my neighborhood. I went to school about 40 minutes away. I took a bus, drove by 4 or 5 schools on the way. But I was in a program where they said we've got to sort of equalize education and make sure that educational opportunities are the same for everybody. And the only way they could do that was to send some kids to schools outside of their neighborhoods, right?
Nice.
And so these programs help, but they're very downstream. How about educational equity and having strong schools in every neighborhood, right? So if we're
Absolutely.
downstream, you make a program and you bus a kid 40 minutes from home so that they can get access to quality education. That's downstream. That almost puts and it also puts the burden on the population that's already disparaged. If we start to move more upstream, you're dealing with not the symptom of the problem, but the causes of the problem. And the furthest upstream is the causes of the causes, the real root problems and the root things that drive all of the inequity that we see further downstream. So I do believe laws and policies are where we really need to be focusing. And then I call it gums without teeth. You can have the best policy, but if there's no enforcement of it, it will make no difference. So if schools were required, for example, to demonstrate you are educating your population at a particular level and they can hit particular metrics, and if not, your doors are in danger of being closed or your resources are going to be shaped differently like that, people would figure it out. The problem is there's no real incentive for people to deal with these problems. To this day, when I was at a previous institution, there had only been one Black full professor in the 100-year history of the institution. And I would say that to people, and I'm not disparaging this institution. It's a place that I love. It's not even about that, because there are plenty of other institutions who will have a similar story. One Black tenured full professor in a 100-year history. There's no other demographic that I could say that wouldn't have people be up in arms. If I said there's only been one tenured full professor who was female in 100
Mhm.
years, people would be up in arms. But there does seem to be this general tolerance and acceptance, or kind of a head tilt. People go, huh, really? Huh.
Right,
But they don't
right,
get up in arms. I'm like, we should be up in arms about this stuff because this is stuff that we can fix.
right,
We can fix this stuff.
right. And can you talk about that a little bit in terms of how do we fix this stuff? You know, the going from policy to translation into the community. How do you attend to that particular gap?
So there's a couple things. So I always tell people, one, data does not make policy. I don't even think that data drives policy. People talk about data-driven decision making, and I
Mhm.
believe in that conceptually. We should be informed by data, but data is not what drives policy. It's policymakers and politicians that drive policy.
Yes,
So you
yes.
want to understand that that's how that works. So if you know that, the question then becomes, how can we use data to better inform and honestly apply pressure to policymakers to implement policies that serve all people? How do we force their hands, make an inescapable case with data for
Mhm.
them to make the kind of policies that we know the world needs? The work I've done around opioids and really unmasking some of that, I think, is a really great example.
Yes.
We had this declared opioid epidemic, and a really great 5-point plan was rolled out by the Department of Health and Human Services. It was very evidence-based. There was a couple $1 billion over several years that then got
Mhm.
funneled into this effort. And the year right before COVID, we saw our first national decline in opioid overdose death. And this is still in the face of illegally manufactured fentanyl and all these other things still in the marketplace. The strategies that we were using were working. That didn't jibe with what I was seeing in my own communities. It didn't jibe with what I was seeing in Baltimore. Didn't, match on to what I saw in DC. It definitely didn't match what I was seeing in Flint. So I took the same data and I just disaggregated it by race. I used the same data that our government used to pat themselves on the back and say, we did a good thing. And when I disaggregated that data by race, what did I find? In fact, the rates of opioid overdose death went down for whites, but it actually went up for Blacks and Hispanics.
That's
But
right.
because the majority of the population is white, it watered down the estimate. They declared a national victory, but they left these two major groups out of it. So all of that money, all of those resources that got rolled out, it worked, but only for whites and not for Blacks and Hispanics.
And can we talk about why those resources worked only for whites as opposed to blacks and Hispanics? Because that's where I find,
Yeah.
well, you can go down the rabbit hole, but it does lay bare those
Yeah.
disparities at the local level, at the neighborhood level.
So I can give you an example.
Yeah.
So one of the things that we know, for example, specifically around substance abuse treatment, is that people can and they do recover from substance abuse and addiction. And we know we have a lot of evidence around what strategies we can employ. So a part of this 5-point strategy was a much bigger availing of treatment services and what's called peer recovery and support services. One of those strategies is starting people on medication assisted treatment for those who need it at in the emergency department or at any hospital encounter. But it's actually up to the individual emergency department whether or not they choose to start that person on medication assisted treatment. And when we started to drill down and look within states, within counties, within communities, Black and brown people were at a much lower rate being offered medication assisted treatment when they were coming into the emergency department. Peer recovery support services, as people, we know people can and do recover, but oftentimes people's lives will fall apart in the face, in the wake of their addiction. They've oftentimes lost family connections, unstably employed, unstably housed. So we know you've got to have all of these things in place so that as people begin to recover, they have the basic human needs met. But the
Right.
likelihood of being able to get in supportive housing In some communities, if you're Black, is almost zero. What you will find in most of those communities is those services are typically more widely available to people who are wealthier, whiter, and to women. So it's not that the work didn't work. We just didn't make sure that everybody had access to that. We know putting Narcan, this very, potent drug that can literally stop an overdose in its tracks. We've done not as good of a job at getting Narcan into the hands of poor people and Black and brown people. So somebody will overdose, and this drug that could be a lifesaver, a literal lifesaver, is just not readily available to them. So it's those kinds of things. So then we have to look at the system. And the way I always tell people is this: you've got to attach the thing that people in power want to the thing that people who are fighting for equity want.
Right.
Right. And what do hospitals want? They want the maximum reimbursement for their services. So if we say you will not get the maximum reimbursement, and we did this work in Michigan, we literally focused on hospitals that had high Medicaid populations, because it happens even within a Medicaid population, right?
That's
We
right.
said, if you want these enhanced payments, and all of them are relying on these enhanced payments, we will tolerate no more than a 5% difference by race and who gets started on medication-assisted treatment in the emergency department. And all of those reasons they had, well, the Black patients are less stably housed, or the Black patients are, less likely to follow up, or they figured it out. It took 1 year and they figured it out. So the thinking is equity has to get baked in. And I love to tell the story of the first time I baked a cake with my daughter. She's about 6, and we bake a cake from scratch. And we're all excited. We go get all the ingredients, because I'm like box cake mom. I'm really not a baker, right? I box cake like that. Nope, she wants to do it from scratch. We go get all the ingredients. When we're done, she's over at the oven. She's looking in. Cake's baking. I'm cleaning up. And what do I notice? The box of Domino sugar on the table is unopened. So we have baked the cake and we did not put sugar in it. And she sees something sort of wrong. She says, "What's wrong, Mom?" I said, "Baby, we baked the cake and didn't put the sugar in." And do you know what she said in her sweet, innocent 6-year-old way? "Can't we just sprinkle some on top?" Now that's cute coming out of the mouth of a 6-year-old.
What we do, isn't it?
A society where we, the people, did not include women or Black people. You got to get, our nation was baked without equity in it.
That's right. That's right.
And we just keep trying to sprinkle it on top. So I say that to say, I think we have to deal with, there's a fundamental missing in how our society was both set up and in how it functions.
As well as how legislature helps to continue, perpetuate, reproduce those baked in disparities,
so
to speak. And I'm thinking, as you were talking about MATs, medically assisted medications, I'm thinking about even the difference of how one particular MAT was basically written into the a national drug or substance abuse act that came out in 2000, where one particular MAT was preferred, and it just happens to be the one that's used mostly by white communities and covered by insurance companies. Versus others. So we see
you're distinguishing between methadone and buprenorphine.
That's it. That's what I'm thinking of. Yes.
Yeah, there's all of these little nuances. I hear a lot, because a lot of my work has been focused around substance abuse, violence, mental health, like that, gun violence. People were up in arms saying no one cared. I was in Baltimore. Baltimore's been dealing with a heroin crisis basically since heroin hit the United States, right? It's a port city. Any port city is at risk for drugs that are coming in by sea, right?
That's right.
And so Baltimore had this big heroin problem. And people said, well, no one cared about opioid overdose, when it was poor Black people in Baltimore dying of heroin overdoses. But when it became middle-class white kids in the suburbs dying of overdoses, now everybody cares. And a part of me is like, that's not the thing that you should be up in arms about. Because the reality of it is the resources that are being used and the approaches that are being used are what we need. The thing that people should be up in arms about is that it's not making it to everybody fairly and equitably.
That's right.
That's the thing to be up in arms about. I don't care how the alarm got sounded. I'm just grateful that it got sounded. Now the work is to make sure that everybody gets it. And we're talking about some of the Black, brown, Black, white disparities, but there are many, right? I do a lot of work now looking at health data disparities, like just understanding the quality of the health record for people. So many people have these negative and avoidable poor health outcomes because the quality of their health record is bad. And that's true. If you are uninsured, your health record is likely missing a lot of important information. Why? Because that information is needed so that when the hospital bills your insurance, they can get their money back. They want to show all the drugs they gave you, how much time they spent with you, all of your conditions. They need all of that for the insurance company to pay the claim. When you are uninsured, there's nobody to hold them to task.
Right.
For that.
Right.
You know, the quality of the health record for somebody with a chronic disability is bad too. And people with chronic disabilities need their doctors, no matter where they're going, to understand and have all of the information so that one doctor isn't treating them in a way that's contradicting how a different doctor is treating them. But those people tend to be not as strong as advocates for themselves. It was frustrating for me. I was a primary caregiver for my stepdad for many, many years. And we would go to the doctors, and every doctor we went to, the first question they would ask him is, what medications are you taking?
Oh, yes.
He don't know what he ate for breakfast yesterday. What do you mean, what medications are you taking? He has an electronic health record. All of that should, and he gets all of his care in the system that he's supposed to get it in. Why are you asking him what medications he's taking?
Right. And these medical systems don't talk to each other either.
But again, this health tech and tequity, technology and equity in technology and health tech equity, that's something we could and should be working on.
Absolutely.
If people were required to make sure that the medical record was complete, they were digitized. It wouldn't matter where you went. These systems could talk to each other. Because again, when you have multiple chronic conditions, all of that information is that much more important for your caregivers to know in order to treat you effectively and avoid unintended but potentially deadly outcomes.
Right. So as you're talking about this, Deborah, can you share a story about how do you organize? How do you bring your team? How do you begin community engaged research that is sustainable, not exploitive, and innovative?
Yeah. So this is a great question. I always say you shouldn't do things to people or for people or on their behalf without their permission.
That's right.
We don't like that. And I do think there's a real history and legacy in the academy of us doing things to community or for community and not doing things with community, right? It's paternalistic to come in and assume that we know what's best. Right. You know, so this idea around community partnered and community engaged research, I think it's the only way we should do it. And what I always tell communities is tell people, no, don't let them in your church. Don't let them come do their diabetes prevention program unless you have a seat at the table and you're a partner. Oh, look, I'm April now.
Oh, yeah, I see that. I look great.
I don't mind. But yeah, no, we should be working in partnership with community. And there is what we created. My partners and I in Flint is called the Continuum of Community Engagement Research in Research. Be all the way down on the end to no community involvement. And you could be all the way on the other end of that continuum in work that is actually being led by community. Look, there's somebody in the background. Go ahead. So I believe the voice of community, if you want to create something that I think is both credible, that is sustainable, if you want something to stick, the people have uptake. If you want to get something baked into a community, you've got to have their buy-in. And I think the best way to do that is to include them as early as possible. And then also be willing to let the community say to you, this is what we need. See, oftentimes researchers go to community with a grant that's already written or an idea that they already want to do. I do such and such a type of work, and this is what I want to do here. When I left Baltimore and I went to Flint, I was a public health specialist. I was focused on substance abuse, violence, community mental health, all in this equity framework. When I went to Flint, did they have problems around violence and drugs and the like? Of course. What they were dealing with and what they were in the midst of was a water crisis. And when I tell you, I handed my research over to the community and I said, you all tell me what you need, and I'll tell you what I understand from the data, but we'll do it together. And I became a water expert. I never worked on water in my life. That doesn't really make sense, but that's what they needed. They needed me to help. And they said, great, but you have expertise in mental health and in behavioral health. So can you be looking at the impacts of this water crisis on mental health and behavioral health and substance abuse? They didn't want me to come in there and design a whole bunch of new substance abuse interventions and like that. They're like, we need everything, all hands on deck to create solutions around this water crisis. So that's a different way to work with community, right? But it doesn't also very well align with the way the academy is set up. You know, the academy is about, especially as a public health person, grants and papers. You have to always tell people publications are the coin of the realm. It's currency in academia. And you use that currency to get tenure and promoted, and you use those grants to demonstrate you have scholarship, and like that. And the two things feed on each other. We call these the perverse incentives. You're not really incentivized to work the way that I'm saying. Why? Because it takes more time, more intention. It won't produce the same level of scholarship. I can sit down and play with a national data set and crank out 25 papers a year. When you're doing community engaged or even community driven research, not that you can't publish and produce scholarship, but the time and attention is very different than sitting at a computer analyzing data. And I'm not saying that that's not important work. The work of making good use of the data that we do have is important work. But the work of also figuring out how do we get things baked in partnership with community is too. And you can't do that kind of work and produce 25, 30 papers out of that work a year.
Right. So in your role as dean, how do you move the needle then?
Yeah.
In terms of in terms of being in this larger context of anti-intellectualism, anti-science.
Yeah.
How do you bring people together in the community in such a way as they can be a part of changing policy?
Yeah. Wow. So the first thing is, I think as a dean, because I always tell people, use the voice, the authority that you have to make the difference where you can, right? Yeah. So I always tell my assistant professors, some of the things that I'm taking on now, you're too early in your career to take those things on. The best thing you can be is a strong scholar. And you can be a community engaged scholar, but I do not recommend taking on some of the institutional fights for equity that I'm able to take on now. But I'm able to do that because I have a track record of, scholarly work, and all of that. So, I always have, there's like a day and a time and a season for everything. Now, as dean, do I get to say, I'm going to change all of the tenure and promotion criteria? No, that's probably too radical of a shift. But what I can say is we can make changes that give credit to things that we haven't traditionally given credit for.
Mhm.
Because the thing about
Mhm.
tenure and promotion, as you know, is much of that process is external. Because I could do whatever I wanted within my own institution. In order for our faculty, tenure system faculty especially, to be tenured and promoted, I've got to have people outside of my faculty,
Mhm.
outside of my university, who say, yes, this person would merit tenure or promotion at my institution. If I can't get them to say that, then it won't happen. But I
Right.
can say to people, in our institution, we've placed value on people working in partnership with community. We've
Mhm.
placed value on people doing public health practice. You know, most of the pillars are around education, research, and service. But we have said at NYU School of Global public health practice matters as well. We are training about 500 new public health practitioners a year in my school. The majority of our students are going right from our wall at our building to public health departments, to state health departments, to NGOs, to global health
Mhm.
organizations, boots on the ground doing the work.
Mhm.
So there are things that you can do institutionally to begin to shift the conversation around what we do, what things that we have historically not valued, but we're trying to have this movement really take hold.
Yes. Thank you for that. Thank you for that. Let's get back to the science of what you do.
Yeah.
You've been around for a while. What do you think has changed or improved as technology and methods for conducting the type of work that you do, specifically, with neighborhood level indicators? Um, what have you seen that's changed or improved, so to speak?
So I think there's a couple of things. One, there are many more scholars who do the kind of work trying to understand the social determinants of health. One of my favorite colleagues is Dr. Daniel Dawes. And he said, I'm not a doctor, I'm a lawyer, but he's in the public health space. He's the new dean at
Mhm.
Meharry's School of Global Health. Um, this idea, he has this really great book, The Political Determinants of Health.
Uh,
We have language now that we didn't even have when I was coming through graduate school, when I was early in my career. We talked a lot about disparities. And I was working with a guy who's a longtime mentor, Tom Levis, who was like, disparities are important, but disparities are the differences downstream. Inequity are the systematic structural things happening upstream. So I
mhm.
do think we now have language. People have certificate programs. You can get a certificate in health equity research or health disparities like that. There are programs now. This is being integrated into curriculum, not just in public health, but also in medicine and in nursing and in all of these other places. So the thought that we're now even talking about these things, we're
Mhm.
training people to do this work. When I did the Nifty was like the hottest thing going. Nothing like it existed. We used to have Palm Pilots. April, do you remember Palm
I
Pilots?
do. Unfortunately, you've dated me here. I do.
Right? We had Palm Pilots and we had this systematic social observation where we could send people out into the community and they would literally, how many vacant houses? Are the sidewalks walkable? Are there indications of drug use? The little crumbs, like the little vial caps that people pop off of the heroin vials, or things like that. The bent spoons that people use to heat up, heroin. The works, the discarded syringes and needles and things like that. It was like no one had ever done anything like that, and now that's like child's play.
so,
But
so
that
what
was
are the next
20 years
steps
ago.
then?
But 20 years ago, we didn't have that, right? Like 20 years ago,
Yeah.
this didn't exist. So now, and my thing is this: while I think the Nifty has so much utility, I love it. It's like a huge accomplishment for me.
Right.
I am like, we need to keep evolving. So one of
Yes.
the things that we did is we took the Nifty and said, can we like get a proxy for the rich resolute data that we get from the Nifty using Google Earth. Because if somebody who's local to the community, who knows what they're looking at, can approximate what we get by sending teams out on the street, wouldn't that be a huge cost savings, a potential new pipeline for people working in the health and health equity space, right? And lo and behold, one of the things we figured out is you can approximate the Nifty using Google Earth.
Isn't it something?
And so we have new, not me, my days in this are over, right? This academic, I won't say administration, I'll call it academic leadership, right?
There you go.
Yeah, that's where we are. A fly on the wall would see an academic administrator and an academic leader doing the same thing, but I choose to frame it as leadership because it just makes me smile more on the bad days. Yeah, this idea about how do we use technology? Because here's the deal. If we can approximate these measures using Google Earth, the resources that we would be doing to do things like the Nifty, now those resources can be deployed in other ways. But I have noticed, I have some scientist colleagues who are so committed to their thing, to their invention, to their thing being the thing forever. I'm like, no, like the Nifty, like I said, the Nifty was like the best that we had at that time. Nobody had ever done that. And now I think there are even new and stronger and more cost-effective ways that we can do that. What remains unchanged is we have to continue to do work to figure out how to both identify and then intervene on the physical built environment, social environment of neighborhoods. Because most, you don't get to pick where you live. Kids don't.
Right.
Kids don't. And we want safe and supportive environments for people to grow up in. We know it makes a difference. And so, yeah, like we need that. So I think one of the things that we've got now, we've got language, we've got many more scholars doing this type of work. We've got people who are figuring out how to leverage technology in ways that are going to be cost effective and cost efficient. But yet there's still the work to do, because despite all of this work, we've made very little progress in closing the health gap for Black and brown people.
Right.
And COVID even made it worse.
Right. So just to follow up with that, what then are the big questions that we still need to be asking to do this research, to do this work?
Yeah, I think we need to have a real reckoning with, there's a real price that we pay for institutional racism. The whole society pays it. Black and brown people pay a higher price for it, like the Black tax, right? Just this additional added burden of being Black in America and just even in the world, right? So I think the work is to continue to reckon with the fact that we still have institutional and structural racism operating all over the place. And we're literally even seeing laws and policies now that are dialing us backwards. I tell people, this is one of my favorite stories. I'll be super fast. This amazing woman named Dorothy Height. Dorothy Height was an applicant to Barnard. It was her dream school in New York in the 30s. Barnard back then had a 2 colored per year quota, and they had already reached it for the year. So they said, sorry, Miss Height, we've already hit our quota, come back next year. And she didn't want to delay. So she got on the train, she came down to NYU, application in hand. NYU admitted her that day. Dorothy Height is one of the most amazing, inspiring people you will ever read about. She ultimately became a nurse. She was very active in the civil rights movement, has done transformative things for social justice. But imagine if she hadn't picked herself up and gone over to NYU. So we had centuries of policies designed to stop Black and brown people from getting in the academy.
Yes.
And people want to act like, oh, but in like 40 years, all of that's been undone. And now we don't have to continue to do the work to acknowledge there's a legacy impact of educational discrimination and barring people from higher learning. that impact still remains today. I was a first gen because it was much harder for my parents to go into higher education. And the thinking that now, oh, we just don't need that anymore. It's not fair. And that SCOTUS decision specifically, which will not allow us to consider race at all in admissions decisions, but will allow us to consider legacy, is reproducing racism, because legacy is linked to wealth and being white.
That's right. That's right.
Those are legacy scholars. Those are the people who were allowed to go in the
Hmm.
30s when Dorothy Height had the doors shut on her.
Yeah.
And so now we can consider you get advantage for that, but no acknowledgement of the disadvantage you face because
Right.
of being Black or brown, and the historical disadvantage that Black and brown people face. So literally, we're watching institutional racism now actually get baked in. So equity was not baked in, but we're watching now overt racism and inequity get baked in. And that's where I'm like, we have to fight. Like, we have to fight. And remember, who makes these policies? The data are clear. The data don't support the SCOTUS decision, but it's
Right.
not the data that's driving the policy. It's politicians. So we have to use our vote. And I do believe this is a part of public health activism and academic activism. We should be using our vote. We should be leveraging the collective voice of our professional societies, of our, um, you know, field, of our institutions. The American Public Health Association coming out and saying this overturning of Roe v. Wade is bad public health. Forcing women to carry unwanted pregnancies is bad public health. Like, that's where we get mighty. And that is something that I think is a movement that's afoot and something that we should all be doing.
Thank you very much. Are there any more stories that you might share about getting communities engaged in research and engaged in this activism?
Yeah, I feel like the communities, and mind you, I've come from the DC area,
Hmm.
very, very active place,
Yes.
Baltimore, and then Flint. And if you've never been to Flint, some of the real warriors and champions of social activism, social justice. I got to work there when I was there with a woman by the name of Miss E. Hill Deloney. She's
Mm.
a living legend. One of her and a woman named Barbara Israel. Barbara Israel coined the term community-based participatory research. Most of that work was done with these partners in Flint. Ella Green Moten, uh, Miss E. Hill Deloney. And here's what's also an interesting fact. Ella Green Moten is now the president-elect of the American Public Health Association. I believe the first non-academic to serve as the president of the American Public Health Association.
Times are changing.
Yeah,
Just
times are
doing the
changing.
same.
Yeah. So I want to just give respect where respect is due.
Hmm.
The idea that I would have to do something to engage them that's about them, I want to flip that around. I think academics and researchers and institutions need to acknowledge and own that we haven't been the best partners with community, that we hold the bag oftentimes, but we're not good stewards with that bag. We're not humble.
Hmm.
Some real things that we did in Flint, we had equity in pay, not equality, but equity. So a community member brings a unique set of skills to a project, to the work, and they should be paid for that. So on my center, I had this very large NIH center called the Flint Center for Health Equity Solutions.
Yes.
The center had 2 projects within it and 4 cores focused on different things. One was on dissemination implementation science, one was on community engagement, an administrative core, like that. Every piece of that center had 2 leaders, an academic leader and a community leader. And they were co-leads. They were listed with NIH. They had pay equity. They had decision-making equity. They had authority over what our priorities were going to be, how resources got allocated. Every publication that came out of that center had academic and community co-authors on it. Like, this is where the rubber meets the road. So that model for how to run us and utilize these resources in ways that are equity centered and honoring of community, the Flint Center for Health Equity Solutions, I think, is a prime example. And
Yes.
then another publication that I did share is it also produced, and you alluded to this earlier, better outcomes. There were sustained outcomes, and it was of cost benefit to the community. I was not asked to do this. I did it electively. We did a cost analysis of the impact of that center on the city of Flint and in Genesee County. And lo and behold, what we found, for every dollar we spent, we saved $1.70.
Isn't that something? So, did these people come to you, or did you have to chase them down, so to speak?
So it's a little bit of both. Remember, Flint is a place where there's a lot of activism. I literally went to Flint only to be supportive around the water crisis. Michigan State University had this new division of public health, really focused it by design on community partnered research. So the search committee that hired me had about 35 community members on it and about 8 academics. So I always tell people the community chose me, but I literally went there knowing the mission and the charge was to build up a community involved, a community partnered research department. So it's a slightly different landscape. So and one of the things I'll say to people is not all institutions hold this as a value. And I'll tell you how you know if they hold it as a value. If they don't have any resources devoted to it, it's not a value.
That's right.
It's just not. The things that they really care about have money attached to them. So if there's no money for it, then it's not really a value. And I know that's sort of a tough pill to maybe swallow for some people because it's like, well, this is my institution and this is the way I want to work. But sometimes it might not be a match, right? Like it just might not be a match. So to be engaged with community, I've always lived, worked, played, and worshiped in the same place. So I am also a part of the community. And I do caution people about kind of being a parachuter, somebody who, you live over here, but then you know, drive. Or I know people who literally fly because they have built relationships with this person or that person and they got them in with the group and they aren't doing community engagement work in their own community. They're doing it in the community where they could get in. So I live, work, play, worship in the same place. So I moved myself and my 2 of my 3 children to the city of Flint when I did that work. I went to church in the city of Flint. I did my banking in the city of Flint. I bought a house in the city of Flint. Like live, work, play, worship, because it did give me an authenticity and a sense of I'm community as well. Now, don't get me wrong. I'm very clear. When sitting at that table with community, they didn't need me there representing community. They needed me there as an academic, as a researcher, as a community engaged scholar, as somebody who was going to bring my expertise, honor their expertise, and we could build things together. But I did have credibility because I was one of them. I was drinking the same water they were drinking.
I'm going to take a second to process that.
Yeah.
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 So before we end, is there anything important left you want to say about this work, your work?
I would say this, and I always like to leave people with something that I think would be of value for them. And one of the ways I do that is I tell one on myself. So I have made a few turns in my career that weren't the right turn for me. I was at Johns Hopkins for many, many years. I did both my undergraduate and graduate degree there. I was at HBCU for a while. I was at Morgan State University. I went to a research firm, Pacific Institute for Research and Evaluation. I went back to Hopkins. I've made all of these different turns along the way. And each one of those turns ultimately helped me to navigate to where I am. And I've had an amazing and rich career. I know I've done stuff that's made a difference. I've learned I'm a better human being, out of all of that. I would
Mhm.
just encourage people to be encouraged no matter where you are. Keep going. And sometimes, in order to make a left, you make three rights,
I know exactly what you're talking about.
right? It's like, and it's okay. But if you really get, you are sort of the master of your own destiny ultimately. How you'll know you're on purpose is one, you'll be doing something that you love. You'll be doing something that you're really good at, right? Like I love singing. I'm just not too good at it. I love it. So
Mhm.
when you love it, when you're good at it, when it's something that is wanted and needed in the world, and
Yeah.
when it's something that you can get paid for, you will find your purpose.
Okay, and we'll end with that. Thank you so much, Dean Verhoeven,
Thank
for this.
you, April. You should just call me Deborah.
I know, but I hold such respect for you.
Yeah.
For this very inspiring conversation today. I'm sure that many will join me in saying, don't stop seeking truth. Don't stop speaking the truth, Deborah, speaking truth to power. Don't stop being your unapologetic self, sis.
Yes. Unapologetically me. And ditto.
Yes, yes, yes. And I want to thank the Center for Family Research for inviting me to be a part of this conversation and for the opportunity of playing host to this very special Gene Brody Symposium. Folks, on behalf of the Center for Family Research and the College of Public Health, thank you for watching. And a recording of this conversation will be available on CFR's website shortly. So have a great day. Devin, please take care of yourself. It was a delight meeting you.
Yes. Thank you for having me.
Absolutely. Live well, everybody.
Yes.